this is a human problem, isn't it? It kind of affects everything. But I have seen it destroy people's lives, careers, and of course families as well. The thing that I hear most often is people being told, you're on your own, live with it. And essentially a lot of our patients that we see are gaslit along the way. This is all in your head. You've just got to learn to live with it.
Do you know, pain is the reason most people leave the workforce in their 40s and 50s.
She couldn't get from the waiting room to my office because she was so bombed on these medications. And she was 92. And
wow.
I said to the family, what's going on? And she said, well, the GP started her on some medication 4 or 5 days ago. And she was just falling asleep in the chair.
But do you know how hard it is to get men to talk about pain? And it's even hard to get men to talk to me. You know, they don't want to show the weakness. I actually know of some federal government politicians who live with pain but won't talk about it. And that, I think, goes to the nut of what we're saying. And then when that GP suddenly goes, they're at a loss and they ring us up and they're crying and they're going, and then they might see someone new who doesn't understand their pain and then won't prescribe for them or won't help them, and they're back to day one.
They always think that pain clinics or pain specialists are last resort. I've tried everything. It's now morphine. Please go to a pain clinic. I ask patients, what did you expect? I had no idea there were pain clinics out there. I had no idea there were specialists like yourself. I had no idea that I had a diagnosis and so many options available to me. People are still suffering with chronic pain. People are still falling through the cracks. They're still not getting the care that they need. What are we getting so wrong?
If you're a mainstream standard, the system works exceptionally well. But when you're that little bit different, and I feel chronic pain is,
what if I told you that 1 in 5 Australians were suffering with chronic pain? And this is chronic pain that you can't measure, you can't see. But I have seen it destroy people's lives, careers, and of course families as well. Despite this and all our medical advances, the thing that I hear most often is people being told, you're on your own, live with it. And essentially a lot of our patients that we see in this clinic are gaslit along the way. This is all in your head. You've just got to learn to live with it. So today what I'd like to do is I'd like to ask a simple question, which has probably got quite a complicated answer, and that is, what is the state of pain in Australia and why so many people are still suffering with chronic pain despite modern medicine? Stay with us till the end because we are going to give you some hope and a way forward. So again, thank you for your time. My name is Nick Christelis. I'm the host of the Pain Diaries Podcast, where we have one honest conversation about chronic pain at a time. Today, my guest is a very special guest. Her name is Monika Boogs. She's the CEO of Pain Australia, which is the national voice for you people suffering with chronic pain. She's not only a policy leader, she's somebody who knows pain firsthand. And essentially, Monika's been fighting tooth and nail in Australia to make sure that we finally take pain seriously. Monika, welcome and thanks for your time.
Thank you, Nick. And thank you for raising such an important question. What you just said then just resonates so much. We talk about that all the time. Why are people with pain being left behind? So it's great to be here and be able to have this conversation with you.
Let's set the scene. Please give us your opening on who you are and what Pain Australia is.
Thank you, Nick. And as you said, my name's Monika. I'm the CEO of Pain Australia. We're an advocacy group, a small but I like to think mighty group, fighting and helping to raise awareness about chronic pain. As you said, chronic pain is something I don't think people know about. I think they know about chronic pain, but they don't really, and the impact it has on people's lives. So we're out there, we're an advocacy group, and what that means to people who don't know is we talk to politicians, we talk to policymakers, we go around the country, and we try to talk to people about the impact of chronic pain and why it matters and why we need better services, treatments, and care. And as you mentioned, and why we need to support people with chronic pain so they're not alone. So that's what an advocacy group does. We've been around for about 10 years, and we were actually formed by a whole bunch of medical practitioners who wanted to see a group try to represent consumers with chronic pain around Australia. I live with chronic pain. My family members live with chronic pain. And I had a brother who has terrible chronic pain from when he was young. He had juvenile rheumatoid arthritis. And why I bring him up is I'm probably like so many people, I didn't understand, even though I saw his pain on a daily basis. Growing up, I didn't really understand. I knew he couldn't do a lot. I knew it impacted his life. It impacted his career choice because he got it quite young. He got it at 17. It's really impacted his entire life. And while I had some understanding, I didn't have a lot of empathy. And until what happens to a lot of us is I ended up having chronic pain. So I ended up I've got arthritis, but mine is osteo. But I was fit, active. And then all of a sudden it hit me in my early 50s. And to go from living with no pain to then not being able to get out of bed was a complete shock. And I had to adjust my entire life, my thinking, how I work, how I prioritize myself, and how I think now I have a level of empathy. But what I want to do is I want to be able to raise that. You shouldn't have to have chronic pain to be able to do and be able to make change. And that's what our role is. And that's what we try to do. Convince people who don't understand about chronic pain that it matters.
Yeah, I completely agree with you on that. The healthcare system, I think Australia's got one of the best healthcare systems in the world. I've lived and grew up in South Africa, so I've worked in the South African healthcare system. I've worked in the UK, in London. I've worked in District UK. And of course, I've worked in Australia, both public and private. Australia's got the best healthcare system in my opinion. But people are still suffering with chronic pain. People are still falling through the cracks. They're still not getting the care that they need. What are we getting so wrong?
It's funny you say that. We've been talking about that a lot lately, about how I think you're right. We do have a great system. But it doesn't mean, I think sometimes we rest on that great system. Does that make sense? So then the areas that people miss out, such as those with chronic pain, unfortunately miss out quite badly. So I get a little bit, while I agree with you, I think if you have cancer or you have the standard things that people understand, have empathy for, it works very well. What it doesn't work, I think, all the time is for people such as those with chronic pain. And I'm often in a room with other organisations representing certain groups who say the same. So I think it was interesting, I was at a workshop on Monday and they said that if you're a mainstream standard, the system works exceptionally well. But when you're that little bit different, and I feel chronic pain is where mental health was 25 years ago. It's booming. It is growing. It is impacting, like you mentioned, people's lives, their ability to work, relationships. It's impacting all of that. But yet our society is still not going, we need to have something about it. And also we are not addressing chronic pain. We address the disease, we address the reason what they cause. Even our health professionals, and you're a pain specialist, but I'm talking about our primary health professionals. We need to educate them. We need to provide that empathy. And that's why I think our pain patients are missing out.
Yeah, I mean, I talk to GPs all the time. I talk to specialists all the time, and looking at it from their perspective, and it's through no fault of their own, they just don't understand what we do. They don't understand what is possible nowadays. If people say, they always think that pain clinics or pain specialists are last resort. I'm done. I don't know what I'm doing. I've tried everything. It's now morphine. Please go to a pain clinic. And that is what some health practitioners still think nowadays. You're just going to get morphine. And I hear that from patients all the time. I ask patients, what did you expect? I had no idea there were pain clinics out there. I had no idea there were specialists like yourself. I had no idea that I had a diagnosis and so many options available to me. I hear this day in, day out. And again, it's through no fault of the GPs or the specialists. When I was in medical school, I got, I think, 2 hours of pain education in 5 years, or it was 7-year course. I literally had one lecture. I remember it clearly. It kind of sparked my interest, and maybe I was one of the outsiders, but that was it.
Yep. And when we hear that all the time, and you think about it, even the system's not set up for pain. MBS items, there's none for pain. So, you go to talk about your doctor's got 15 minutes. They'll talk about that condition, the next aspect or the other aspect that's just as important is how do I manage the pain? And like you said, there's so many ways. We could look at, helping people with preventative programs to manage it, to live better. And one of the things we talked about just the other day, quality of life is just as important as treating your illness. And that's where I want to focus with pain, because I think that's where our pain patients miss out so much.
What are some of the big projects you're working on at the moment?
One of the things we're working on, which came up when there was the debate about a year or two ago about upscheduling paracetamol long modified, okay? And for people who aren't sure about that, what that means is you would have to go to a doctor to get your Panadol or your paracetamol osteo. So we thought that wasn't right. That wasn't right for people with pain. Often they rely on that sort of over-the-counter medicine. And so we actually did a lot of work in that space. But when we talked to our consumers, it became very evident that even the ones who deal a lot and are very literate and educated, they were asking questions like, can we have vitamins without over-the-counter? And what about our prescription medicines? So you're smiling because I think you hear that all the time. So what we're doing is we're working with this fantastic group of consumers. And gosh, they're tough on me, but I love it. And they say, we would like to get a guide. In fact, there's too much information. We just want something really simple that can help us know what to do at home, and then help us then to talk to our doctor, to talk to our pain specialist, but something that helps us very simply. So they're building this guide for me, and they're designing it. And we're going to launch that next year. So that's a really simple piece that we're doing. And then we do everything from working on that to actually a piece I want to do is I want to next year highlight and focus on the cost of pain. The cost of pain on our community, on the cost of pain on a patient, and the cost of pain on how we can't work. The cost of pain on your family. Because I think in today's time of cost of living, that is something that will be able to resonate. Everyone can use it and everyone can relate to it. And then we could go and take that to the policymakers. So they're sort of the big projects I'm working on, but also bringing consumers in. I love the consumers. It's not about me. It's about what our patients want. So I want to talk about that. And the other third thing I want to talk about, and we're starting to talk about, and it's a little bit left field, Nick, but I want to talk about men and pain. Because women and pain is so important, and we're having a fantastic conversation. But do you know how hard it is to get men to talk about pain? And it's even hard to get men to talk to me. They don't want to show the weakness. And that's the conversation I want to have that's also part of a broader conversation. You are strong if you talk about your pain. You're not weak. Let's flip it.
Yeah.
Because I think that's when we get people to talk about it.
I see men with pelvic pain all the time, but it is really hard to get them to share their stories with us. And it's really hard sometimes to actually just get them to come into the clinic. So we work with quite a few urologists who know how to talk to their patients, and get them to come and see us. So we have a small group of men with pain, like, men's health pain, pelvic pain. And it is a difficult conversation because they feel like they shouldn't be talking about it. So I think that's a really good discussion topic. And I'm sure you and I can talk off the scenes, but we'd love to maybe pen some stuff for you, because we see this, we see this not as often as women in pain. And that's another discussion, why are 60% of pain clinics have women and 40% have men? Is it a women share things better? Is it a hormonal thing? Is it something else we're missing? Is it a genetic thing? Is it just purely that men are not sharing with us that they are suffering and struggling in pain?
And I think that's a great conversation. And even we talk about that all the time. All those things you just brought up. So just a little aside, I'm part of a research group for pelvic pain, okay? And they're actually looking at pelvic pain. They wanted to recruit men as well as women. They had a fantastic response, and we helped them get consumers women. They couldn't get any men. So funny you say that. They actually can't. So they're the stuff, because what I want to do is, I don't think as a sector we're being great about talking about pain because the stigma associated with it. So if we start talking about it, hopefully the stigma, because people dismiss you. And in fact, I did a radio interview recently and the person said, oh, well, do people not do it because they're just whingy? And I thought, that is terrible language to have. But that's what people could think. And people, as you know, they just go, okay, people are sick about hearing my pain. I'm not going to talk about it. And I think that's a real shame because we shouldn't have that situation. People should be able to feel that they can talk about their pain, be believed. Because how many people tell me that they've been told by their GP or their whoever that it was something that they, it was in their head because they can't find. No, pain is real. It's invisible. That's the problem, but it is real.
Yeah, I've got some patients that I can just think of offhand because obviously in this clinic, we've seen since inception, which was nearly 10 years ago now, we've seen nearly 25,000 patients. So I've got these pictures and stories in my head. I've got a group of patients, they come in to see me and essentially the consultation, they are crying through the consultation. And one of them, I said, well, why are you doing this? And she said, I just want to be myself in front of you. And I'm not myself when I'm outside and when the door is, when I'm out of this door, I'm a different person. I put a different face on and I just get on with my life and I suffer in silence. I mean, it's a cliche, but that's exactly what they say. I suffer in silence. And when I'm here, I can just feel like I can just let that barrier down and it all just comes out. So it's a massive, massive problem. I can't share patient stories because that's, I can't do that. And I can't have patients on here or certainly our patients talking because it's just not allowed. It's just the APRA rules. But if you have spoken to many, many patients as well, but both in the clinic, in the cities and in the rural settings. I mean, what's the big difference between cities and rural settings? Because my impression is that there is not much out in the rural setting and we see patients from all over the country and some patients travel and fly to this clinic to see us. So there's a massive disparity out there.
Look, it's so true what you just said. We talk to people from regional and rural areas a lot, and we've done a lot of surveys and even discussions, and I've done a lot of interviews. And I've got a couple of people who live even on the south coast of New South Wales or in rural areas. And they talk about, like you just spoke about, they travel hours to see a GP, let alone hours to go and see someone else who can help them. But then also they don't have access to physios. They don't have access to even basic hydrotherapy that you could maybe help with manage your pain. They don't have access to so much. And then what they talk about is, and it's really interesting, some of them have great relationships with their GPs, all right? But then, as we all know, GPs in rural areas are aging and disappearing. And then when that GP suddenly goes, they're at a loss. And they ring us up and they're crying and they're going, and then they might see someone new who doesn't understand their pain and then won't prescribe for them or won't help them. And they're back to day one. And we hear that a lot, that loss of and changeover. It's interesting. I hadn't thought of that myself until I was hearing those stories. That I had a great GP, but he got old and he retired, and now the new one or the other one's 3 hours, and they don't believe my story. So it's actually been...
And they won't prescribe my medications.
Yeah. And, I've been managing it, but, and I feel like I'm a drug seeker because, we all have that for poor pain patients. So it's really interesting that is the stories I hear. And while it's difficult to access services, I think in the cities, you can't, once you know or find support, you can sort of navigate it. But in the country at the moment, unfortunately, we are going a little backwards. And one of the things I say all the time is I think pain has gone a bit backwards. Once upon a time, you could get a bit more help. But I think now there's a lot of stigma attached with pain and there's a lot of stigma attached with the treatments for pain. So I think we've got a double whammy, and that's the issue.
Yeah, I come from the medical perspective, and the way I manage patients, or the way we manage patients, is there are 5 approaches. One is lifestyle. So we spend quite a bit of time talking about lifestyle. We've got a dietitian in the practice, and I've seen her myself because I've learned so much from her. In fact, I did a podcast with Sherry. You should watch it. So lifestyle, managing stress, moving your body a little more, sleeping a bit better, not drinking too much, not smoking. That's preventative medicine. Then you can move on to the allied health approach, which is the physios and the psychologists, which we'll come to in a second. Then there's the medical approach, which is there are many medications that are non-opioids, and sometimes even a little bit of an opioid can be helpful, providing it's done in the right way. So there is the medication approach. If those things are failing, then you can move on with caution to using an injection to diagnose and treat pain. And some of the things we do nowadays can change people's lives. It literally can. And then on the fifth side, perhaps it is a referral back to the surgeon for consideration for surgery, or some of the advanced pain therapies that we can use in some instances, intrathecal medications or even spinal cord stimulation, as you know. But one of the things that I think we're getting wrong, and this is my opinion, is we are moving so far away from the medical side of things to it's all in your head. And whilst your head is an important part of pain, because we know that the pain experience is here, you still have neuropathic pain, you still have central sensitization, you still have all these medical pain conditions, complex regional pain syndrome, nerve entrapment, nerve impingement, those kinds of things, which are real.
Mm-hmm.
And so I think we've flicked away from using a medical approach to we're going the other way now to we're just going to sit down and we're going to talk out your pain. And talking out your pain is never going to work completely. It's got to be a bit of everything.
And it's funny you say that because
what do you think?
I think exactly that. I think it's a bit of everything. And what I say is it's everything. But for some people, it could be everything. For some people, it could be 2 or 3 of those things you mentioned. For some people, it could be just a surgical intervention, believe it or not. Everyone is different. And we shouldn't, I have that very similar view that you've just talked about. I think, and what we say as an organisation is we don't favour one or the other. They all should be available. They are all important and we should support them all. So I know there are views, like I look at my brother who lives in he's an extreme case of chronic pain. Look, he doesn't drink, he doesn't smoke, he's slim, he walks everywhere, he does as much as he can. That's never going to fix his chronic pain. His body is riddled with rheumatoid arthritis. So, that's it's not going to fix his pain. It's going to maybe help his sleep and all of that and his mental health.
Sure.
But it's not going to fix his pain.
Yeah.
Other people, I had a lot of pain, as we talked about. I manage it. For me, and this is just for me, surgical intervention was good for me. It worked really well. But now I do a lot of physio. I do a lot of preventative. I do a lot of water-based exercise. I exercise twice a day. That's a lot of exercise. I exercise morning and night.
Music to my ears.
To get my knee moving, so I can manage my pain and manage my flare-ups. But what I don't want it to do, and I've like you seen that conversation, that it's all in your head or we can't believe it, or if you just change your lifestyle, you will fix it. I think it's dismissing too, and I've had people ring me up in tears going, people didn't believe it. I've got migraines. They wouldn't give me my migraine medicine. They just told me to wait it out, I just think that approach of, get over your pain, or if you manage, or it's your fault, and if you maybe lived a better life, your pain wouldn't be there. And I hear patients say to me all the time, I feel like it's my fault, and it's not. It's not. So I'm with you. I think it's look, everyone says this, but it's true about pain. Pain is complex. And every single person's pain is different, and every single person. And I think why it's so hard to treat pain is, better than me, but I found it myself. Finding that combination takes years. It took me 3 or 4 years to find the combination that worked for me, and that's hard.
And it shouldn't be hard. And especially now with the advent of the internet and all these platforms that we can use and all these apps that you can build, Patients are still struggling. Patients are struggling massively. So if you could change things, what would you change? How would you change things? Would it be a societal change? Would it be a medical change? Would it be a governmental change? If you had a blank slate and you can do three big things, what would they be?
It'd be societal one, because I think then there'd be an impetus for change in other parts of our community. So it's about making sure that we actually genuinely care and empathise and understand that pain is not something to be dismissed. But also, you just touched on two things. It's about being able to have the money and the funding to be able to then educate and help the health professionals. So it is government and medical, but like you've just said earlier, you know better than me, no doctor, no health professional is wanting to dismiss someone. But sometimes they're at a loss how to help. I remember sitting with my GP crying because I couldn't even describe my pain. And that is something we're actually working on. We're working on a tool on how to describe your pain. And in the end, I ended up describing that I felt like I was burning up inside. That was the best. Now, I'm an ex-journalist. I can describe words. I couldn't describe my pain. So if I can't describe my pain, how can the doctor or the GP or anyone even help me? So I think it's about everyone being educated. And like you said, we need to put education into medical education. We need to be able to have people be aware of it, and also but it comes back to money, and everything comes back to money. But I think at the moment, why with pain we haven't had that impetus for change is because we don't yet have people caring about pain. It's not you only change. The system only changes when there's enough people to say it needs to change. And at the moment, again, that's why I think it comes back to society first. We're not talking enough to then have the people who can make change and improve our system take notice. So our job is to do exactly this, talk about your pain.
So exactly like we're doing now, and that's partly why we're doing what we're doing, because I'm sick and tired of seeing people suffering and struggling. And if we can get through to one person with this discussion, then it's been worth our while. And if that person get through to another person, then it's worth our while. I've always said, in terms of policymakers and government, let them just sit in a patient's shoes or stand in a patient's shoes just for a day and see what they feel like, and things will probably change then. But until then, I don't know. I mean, you're the voice of 3.2 million people in Australia, essentially, and that number is changing all the time. Over the last 5 years, I've seen people become younger with pain or more pain. I've seen pain become more widespread. I've seen pain become more debilitating. People feel more isolated. We've clearly had patients that have died accidentally because of too many medications. I saw a lady 3 weeks ago who was brought in by her caring two daughters, and she'd had severe shoulder arthritis. And the GP, through no fault of his own, had given her medications, pain medications, and she couldn't get from the waiting room to the clinic, to my office, because she was so bombed on these medications. And she was 92. And
wow.
I said to the family, what's going on? And she said, well, the GP started her on some medication 4 or 5 days ago, and she was just falling asleep in the chair. So I've said to them, we just got to stop all the medication. And that's all we did. I stopped the medication. We use a medication called orphenadrine, which is Norflex or Norgesic, which is a very simple, very old medication. And it works quite well as it's not an anti-inflammatory. So it's quite a simple medication. 92 years old, gave her a little bit of Norgesic, got her to stop the opioid that she was getting. And I saw her recently, a couple of days ago, and I had a conversation with her for the first time. The Norgesic was helping. So we had to start off by clearing out her system before I could do anything. I had to clear out her system so I could talk to her, examine her, do what I needed to do, give her some very simple medication. And she's about 15 or 20% improved already. So she's happy with her progress. Clearly, we've got some other things that we're going to progress on to do. We're going to work on her shoulder. But it is completely different for everyone. And everyone just knows to add medications into the picture. And if patients are getting older and living longer and having aggressive cancer therapy and aggressive surgeries just for medical conditions, they end up on a host of medications, so polypharmacy. And of course, when you've got pain, you're on a bit of an opioid, you're on an antineuropathic medication, and they all are trying to suppress the nervous system. That's what they do. They suppress pain. But of course, they suppress the big nerve as well, and it can have profound impact on some people as well. So we spend a lot of our time using injections and interventions to actually simplify patients' medications. And more often than not, they help. They simplify things. And I've never had a patient say to me, that was the wrong thing to do to wean down some of my medication. It's taken hard work, lots of discussions, lots of getting the patient on side before we've taken those steps. But never has anyone said that was the wrong thing to do.
It's really interesting what you said in a lot of aspects just then. One of it is the politicians. I actually know of some federal government politicians who live with pain but won't talk about it. And that, I think, goes to the nut of what we're saying. They don't want people to know about their pain. It is nuts. So, I've been asking them to talk about it. No, they won't engage, because even for them, it's seen as weak. If they're up at Parliament House, they would be seen as weak. And I've actually had those conversations that you're just saying. I've said to people, do you know, because I think, it's the elderly or whatever, and even if it is the elderly, we need to care for them. But I said, actually, do you know that the biggest driver for people leaving the workforce is actually pain? Do you know pain is the reason most people leave the workforce in their 40s and 50s? So if you're in early retirement, you are generally an early retirement because of pain. It is one of the biggest reasons people leave the workplace. So, and then they spiral, and then it's like you, we were talking about, then they have, and I think it's really fascinating when people go, so it's not just older people. I go, no, in fact, it's the 40s and 50s are our biggest group of pain people. And you're nodding your head, so it must be what you see coming through. I said, but people don't understand. That's the years where pain hits. And they're suddenly at work. They don't want people to know about it because they can't be seen to do their work, And if we are having people who aren't even, we're having a few people talk a little bit about pain who are high profile. You can just see it happening. And that's why I say we're where that stage of mental health was 25 years ago, when few people are starting to go, I live in pain. But we haven't got that mass movement yet. And what we need is the people who people will follow to go, I have pain.
Yeah, I have treated AFL superstars. I have treated Olympic athletes. I have treated some of the very highest in society, if you want to use that as a term, people with massively prominent figures. And similarly, they just don't want to share their stories. And we see it all the time. I've treated some very famous Australian, not celebrities, but TV personalities and things, and they do not want to talk about it.
Yep, I've interviewed them.
It is, so yeah.
Yeah, I've interviewed them.
So if you've got,
talk about it, they say no.
Yeah. So you've got this group of people out there suffering in silence. You can't measure pain. You can't see pain, apart from CRPS, which is another discussion. So you've got people suffering in silence. You've got politicians that are not prepared to talk about it. You've got medical personnel and healthcare professionals. A lot of them don't understand it. You've got 400, I think, registered pain specialist physicians through the Faculty of Pain Medicine, supplying pain services to 3 million plus people. And obviously there are people with an interest in pain as well, but not specifically trained by the Faculty of Pain and got the higher qualifications. What are we doing? Where are we going to, you said we need to talk about it. Fair enough. You need to keep banging your head against the politicians' doors. What is the trigger? Are you seeing some green shoots? Are you seeing some light at the end of the tunnel?
Little, because like I said, you can see just a few people talking about it. You can see a few people willing to come out. I think we're at that early stage, and I have to admit to you sometimes, and you find this when you work in the health system, sometimes you think, it's just so big, it's so huge, what am I doing? And then you talk to consumers and you talk to patients. And, I had one who said to me, I have such bad neuropathic pain that I actually bang my head against the wall because it relieves the other pain I'm feeling. So when you have people tell you that,
Yeah.
if you have someone who literally tells you that, you think, wow. And it does help you keep going. It does help you go, okay, I've got to tell that story to as many people that I can, because that's not normal. But that shows the desperation. And I think that's what we have to do. We have to be not afraid. And I'm trying to build up, we have this fantastic group of consumers who are very, very passionate because they've come through pain for 20 to 25 years. They come to us when they've had a very long pain journey and they're like, I want to share my story. I want to be there. We've got one is a nun who has had something like 35 surgeries. 35 surgeries.
It is nuts.
That's a lot of surgery. So, but we keep going for them, as you know, because if we just go, all right, we'll give up. And I figured, I don't know how mental health must have felt 25 years ago, mustn't they? They must have gone, finally we're going to break through. And I think what we want to do is we want to do a few things. We want to break through, but we also, and it's people like yourselves, we've got to keep people like yourselves involved, looking after pain patients. How do we get more people want to specialise in this area? What made you do this? You said pain piqued your interest. Well, how can we make it more attractive for people?
Yeah. I mean, it's tricky because currently now, if you want to be a pain specialist, you need to be a doctor you need to be specialized in something, whether it be general practice, anesthetics, which is the bulk of us are anesthetists by training, rehab specialists, general practice, and we've got a smattering of other specialists like neurosurgeons and gynecologists that make up pain specialists. But on top of that, on top of your primary specialty, then you need to do another 2 years. Mm-hmm. And that involves exams, it involves jumping through more hoops, it involves in some instances taking a step down. I was a pain specialist in England, consultant, and when I came to Australia, I had to take a step down. I had to resit the exam before I could be seen as a local. And I had people, that's probably another story, but I had people saying, you're never going to make it here because you're a foreigner. I literally had that when I got here and I was fishing around and visiting people and getting a sense of things. And that's why what I've said is we've got an amazing practice here. And, hopefully one day when you're in Melbourne, you come and visit us. But we've got 10 pain specialists and we're from all over the world. And I vehemently disagree with people saying you're no good and you're not going to make it, because we need more pain specialists. My dad, when I was in London training as an anaesthetist, my dad had pain, severe back pain, like so many other people. And he was in Johannesburg, and I saw him being, put through the ringer, and no one really knew what to do and how to help him. And I found a neurosurgeon in London, and we got his scans brought over. And of course, we didn't have just a flick and internet in those days. And I found a neurosurgeon which helped make the diagnosis. And then he had a microdiscectomy, and he was fine. This was after 2 years of being gradually broken.
I think the world does better on pain. So I think there is some hope there. One of the messages I get from consumers, they say to me, we just had Awareness Month, like September is Pain Awareness Month. And they said to me, I said, what message would you give to a health professional? And they said, the message I give is, as a person with pain, see me and also see my pain. And so I want you to see me, and I want you to see my pain, and then I want you to treat me. And it was really interesting because what she was getting at is she didn't want her pain dismissed. She didn't want she to be dismissed. So I actually thought that was a really clever way of talking about what you just talked about with your father and about it being invisible. See me, see my pain, and then let's talk about how we can manage and work and treat it. And it's a really powerful but simple message, and that's the kind of message I'm even taking away, because I thought, wow, and this is a person who has terrible pain and struggles to have people believe her pain.
It's the same thing every time. People need to share their story from scratch, and I think there are the thing about pain is it affects every single aspect of medicine. It affects pediatrics. It affects general surgery. It affects urology. It affects gynecology. It affects neurosurgery. It affects orthopedic surgery, shoulders, joints, hips, knees. It is in every aspect. Of course, general practice as well. GPs see the bulk of the pain patients out there. So does that mean we need to educate every single specialty, or do we have one education central repository where they kind of get stuff? Part of what I'm doing is I'm trying to, well, not trying, I am putting together a little bit of a group of knowledge for those that are interested. And that's partly what this is. And, me reaching out to you and us talking at various conferences, how can we go about sharing the knowledge? And I think that's a big thing that Pain Australia is doing, but we still need to do more. And like I said to you when we were planning this, perhaps if you can get one or two advocates or one or two patients that are really keen to share their story, let's put them on and let's have a discussion about things, because eventually we will get through. And I think the COVID pandemic really changed things as well. I mean, as we know, and we're still getting over that because society changed massively because of that. People were isolated. We still worked through COVID. We just did it online, and we obviously changed how we approach patients, but we got through it all. The effects are still lingering because there are many isolated people out there.
Look, I agree 100%, and I think we need to do two things. I think building that knowledge to then be able to share to other groups is really important. I am seeing, though, when you talk about hope, I have had a lot of engagement, and I'm starting to get engagement from people like, and it's all post-COVID, the Australian Orthopaedics Association. They're like, can you come and talk to us about pain? And I would never have been invited by a bunch of very highly skilled, professionals who go, can you come and talk to us about patients and what they think about pain? To me, when you talk about hope, that's fantastic. So it's really interesting. Yeah. We are starting to see, I feel we're at that stage where we could really make inroads, or we might not. And I think that's part of also what you and I have just talked about, what we're talking about. I will get some patients on to talk to you, because I think that's where people go, wow. And in fact, the orthopedics had asked me to present at their conference, all right, at a dinner they were having. And I said, look, I can't make it, but I'll send a patient. And we ended up saying the person who went was the nun. And it was really interesting because it actually happened to be, I don't know if people, know, but it was like Ash Wednesday. And so she wanted to say, they were there ready to have a meal and have their drinks in here. And she wanted to say a prayer. And she said, all of you stop now, say the prayer, and I'm going to tell you about my pain. And they were just enthralled. And I thought, isn't that fantastic? Because that means that group of orthopedic surgeons are going to then go back to their patients and have a little bit more. They might just think. So that's what I think we need to do, Nick. We need to, like you just said, use that knowledge that a pain specialist has, that we have, that patients have, to then get out there. It is happening, but we do need to do more, and we need people willing to speak up to do more.
Pain Australia has been very quiet over the last decade, and perhaps stuff is done in the background. You'll know more of that than I do, but certainly since you've come on board, you're in a lot of places. How do you find the time to get everywhere?
I have to admit to you, I say yes to everything, and I actually said, I don't know how long I can keep this up, but I think maybe it is because I've lived with pain, and maybe because my background is an ex-journalist and an ex-political person, where I think, we need to just get out there and talk about it. So, and I don't mind talking about my pain. One of the things I struggle with, and I think we do, and I've got this fantastic consumer, is people think you don't look like you live in pain. And we've got to dispel that myth too. And this woman is in her 30s, terrible pain, okay? Yeah. She's here in Canberra, drives a little sports car. She has driven up, parked in disabled places, and have people abuse her because she doesn't look like she's in pain, there she is. And then she tries to tell them that she has pain, and they go, well, you drive a sports car. You shouldn't. If you drive how can you pain and drive a sports car? I know. So isn't it amazing? And I tell that story as a bit of a nice story, but also what a pain patient's supposed to, are we all supposed to? And there are days that we are terrible. As a pain patient, you see that there are days that I can't get out of bed. There are days that, but at the the same time, we need to be treated whether we look like we're in pain or whether we don't look like we're in pain, because we don't expect a cancer patient to look terrible. In fact, we bolster them up to try to make them feel good and look good. But we don't do that with pain, do we? The psycho stuff of pain is just fascinating for me. And I think that's why I'm out there talking about it and saying, you got to think about people in pain. We've got it. And even I was at a workshop, and we were at a workshop with all these patient groups on Monday, and a bit like you just said, they were talking about their cancer and all this. And I'm going, but what about the pain patients? No one has once used the word pain. Sometimes in these beautiful government documents, they'll be 400 pages long. You do a search for pain, and it's not there. That's what we have to change.
Yeah.
Because until, and then even a few people went, I was talking to them, I said, and one of the things, and this is something I said, we even talked about this, and it was another person who agreed. I said, and sometimes we even have to talk about the bad bit of pain. Sometimes it can impact your mental health, and it can be linked to that so much that there's even an issue of suicidality with pain. And people went, yeah, we don't think about pain like that. And I thought, these people who are advocating for their own disease state, and they were actually going, we don't think of pain patients like that, or people, or our patients who will have pain. I said, no, because you talk about, dealing with, like you just talked about, whatever the condition is, but they don't talk about the pain. And that's really important.
It's terrible because even pain patients don't know how to approach it at times. If you've got hopefully some audience watching this, the people with chronic pain, particularly in Australia, but of course worldwide, they can all jump onto the Pain Australia website, which we'll put a link in. What can they get from you immediately if they go to Pain Australia, apart from all the advocacy you're doing, apart from all the projects you're doing?
Yeah. So what they've got is, we actually have a directory of pain specialists, a directory of allied health people who specialise in pain. So they can actually go and find support, particularly people find that really useful if they live in more regional areas. So we have a directory of not just pain specialists, but you might have a physio, or you'll have different type of professions who, like you said, have an interest in pain. So they can find some practical services there. They can find resources, some information about all the types of pain, all the different types of pain, so they can find some information. Because there's, you talked about complex pain, regional complex pain the other day, earlier today, and we had someone come to us. She was a person who has that, but she's also a medical specialist. So she wrote a little bit of an information guide. So we had it checked out, we had it approved, and we put that on there. So there's some really helpful resources for people about where they can get help. And then on top of that, we also have the stories. So you can see, and the messages from different patients. We have videos, we have quotes. So you can see other people have worked through their pain, get their ideas, how they've found support, and also just realize you're not alone. So there's a lot of that on the website as well.
Great. And I'm just having a look at the website, and as I said, we'll have some links and possibly some screenshots of some of the web pages for patients to go to and use. Yes. Patients can donate, of course, as you're a non-for-profit organization and you're there for patients and advocating for patients. There are some pain fact sheets on various conditions. You've got a blog as well. I note that there's something on opioid safety. Is that something that you're quite a strong proponent for? Give us a couple of sentences on that.
Well, we took part in an opioid safety, developing an opioid safety toolkit with Monika.
Well, I've got aphids. Yeah. Tell us more about that.
We were really active in that, and our consumers. So if people also want to volunteer and work with us, they can always drop us a line, because we had some of our consumers actually sit and develop that toolkit, and they had all had experience about opioids. Some of them had used it and stopped using it. Some were still using them. And so we believe, again, that, like you talked about, for some people, if you talk to your doctor, you need to talk to your medical practitioner. However, it's really good to know about the issues and the safety issues. Take home naloxone, all that sort of stuff is there, and that is really important. So we do a lot of, I think there's, what I would say is, when you're trying to find all this different information on the internet, if you go to our website, it's focused on pain, and it's all been approved and gone through medical practitioners and approved and made sure. And there are times, we say, go to your medical, when we're not a doctors, we're not a medical device, but what we do have is we have some fantastic people who are heavily involved with us, who are medical professionals who do advise us to make sure that all of the stuff that's on our website is safe and helpful for patients.
And just flicking through your website, there's a little bit on the real-time prescription monitoring as well, which is a means for practitioners to see what patients are getting prescribed, if they're getting prescribed from multiple different locations. And whilst it is a benefit because I can see what the GP's prescribed, particularly with scheduled medications, whether it be local or in the regional areas, there are some issues with real-time monitoring because it makes patients feel like they're being checked on. It makes patients it makes patients feel like they are part of the problem. So whilst it's probably a good thing, it certainly doesn't appear to be supportive of patients in that regard. I mean, are you getting the same sense of that as well?
Nick, I think you read my mind there. We get that sense so much. And in fact, I did a report, and it is a private report that was done for New South Wales Health. And I have to commend them because they wanted to hear from patients firsthand. And I followed patients over 12 months who then said, we feel like drug seekers. So they actually gave that input to New South Wales, who've made a few changes, which I'm very pleased to say they've done. But that shows you that practical help that we can do, because you're right. I got a lot of people telling me it's really bad when you're in a pharmacy and you're being questioned, or a GP, and you're just like, I had to go through this and I'm now in public and you're having to go at me about my prescription.
Yeah, I'm in the pharmacy and there are people all around me, and you're starting to quiz me on opioids and things, and this is not a quiet space.
Totally. That's exactly what
terrible.
They said. It is terrible. They said, the thing that came across, they said, it felt like we were drug seekers. And they've even been refused. And they've even said, well, how did you get this script? And they're like, from my GP, of course. God. So it really interesting you brought that up. That's been a bone of contention, and we have actually provided a lot of feedback, and I'm even on a stakeholder group with ACT New South Wales. Some states are better than others, but they do like to hear about our point of view.
Good. I mean, I think, as I said, we need to let people know about what you're doing, because you are doing some amazing stuff. I have an interest in using advanced pain therapies, and I see on your website as well, one of the things that you see straight up is there's an information area with little videos on spinal cord stimulation. That's been a bone of contention recently, hasn't it?
It has. It's been a great bone of contention. And again, we go back to the fact that we support, if it's safe and approved by the TGA and our medical authorities here in Australia, we believe that these should be available if a medical practitioner says to their patient, this is what should be, you should go down, and they decide together. So there's some really good information there. Again, I've had consumers say to me, I literally was lying on the floor on a mattress, and that young person I told you about who was in her 30s, who was driving the car, she has a stimulator, and it changed her life because she was a workplace accident. So, again, our view is we provide the information so that you can see what's available, and then you go and talk to your medical professional. And I think it's about saying to people, like you said at the beginning, I love the way you said, there is so much there. It's knowing what's there and working through it. So we try to do that, help provide in that one spot, and then you work with your medical professional about how to deal with your pain.
Yeah, I mean, I've been practicing advanced therapies for more than 10 years now, and I'm an advocate for it to be used if and when appropriate. Like anything, there are people that it changes their lives from one day to the next. But of course, it's got some technical issues. That of course, there are risks such as infection, but of course, it needs to be done by somebody that has the appropriate training, and of course, more importantly, the system around them to actually deal with the therapy. And as you know, there have been some negative news stories out there, and it feels like in the pain world, we're constantly banging our head against so many obstacles. Government obstacles, policy obstacles, real prescribing obstacles, patients getting dissed and gaslit obstacles. There are just so many obstacles to manage pain. But I will keep going and I will keep doing this. You will keep going and you will keep doing this. And we'll probably need to meet up and have a drink or a glass of wine regularly to keep us going, because, and again, just something personal, I have days where I am exhausted managing some people, because it can be exhausting even for us managing people with pain. You know, imagine seeing 2 or 3 patients, one after the other, and they take off their veil and they just let you have it when you're in a consultation, and you do that and you see 20 patients a day or something. And by the end of the day, you're cooked, you're done.
And I say to people, sometimes you think about it, if you're in constant pain, sometimes it means you can have your moments, can't you? And that's understandable.
Yeah.
You know, and so I say to people what you just said before about politicians. Think about if you're in constant pain all the time, and and that's why it is exhausting for families, and it is exhausting, but we still have to, I think what you just said, keep going, make sure that we have that level of support around people who live with pain, provide them the options, and also make sure that people who are at their workplace or with their families do have that empathy for what is an invisible condition and that understanding.
Yeah.
And I think the problem, like I said, we hit ourselves, we have pain, we think, oh, we got over that, you can get over your pain. That's not the pain we're talking. So I'd like to tell you, I have, like I said, some beautiful consumers who work with me. And I get a bit confused. I don't know whether or not, and I love that feedback from people. Is it consumer or is it patient? If anyone ever wants to provide me feedback, any of your listeners want to comment when they see these videos, please tell me. But so I go between the two, and I don't know what people want to be called. But she said to me, and I've got it here to read to people, hope is such an important thing. I learned how to accept where I was in my life and that my pain was what it is. But acceptance doesn't mean resignation and resigning to my pain. So it was wonderful. And this is a lady who's had a lot of pain. She has had CRPS, and she has lived with it for 25 years. So for her to say that finally she got to accept her pain, and I have lots of people who tell me that they manage the pain. They don't take away their pain, but they learn to live and focus on what they have, not what they have not. Now, these are people who've lived with pain for years and years and years. But I just wanted to let you know that even gives us that hope, because I think that, to see these people say that they can finally accept it is something that I think gives us all hope to keep going.
Massive. Yeah, agreed. And I completely agree and concur with you on that. Acceptance is a massive factor, and everyone gets to that point sometimes in their own time. I've had to say to people that are under the compensation system or having medical legal stuff happening to them, you are not ready to move forward, and you've got to get your medical legal stuff done. Before we can move forward, I've had people where I've had to just sit with them, talk them through it, and they've come around to it. Now, I've had to use psychologists to help people come around to it. I've had some things when I was much younger that happened to me, and it took me years to accept it. Years. So it does take time. And when you bring up some of these things to patients that are not ready for it, they kind of shut down, because what do you mean? You want me to accept that I'm going to be in pain and suffering? No, I do not want you to accept pain. I do not want you to accept suffering. I just want you to accept where you are right now.
And
you just got to accept where your life is right now. Correct. So I wanted to say thank you for your honesty. You're doing some amazing work out there, and from me to you, as I've said to you before, I am ready to help you in any way that you need. So you just have to let me know. If it's writing an article, if it's working on a project, or I will find the time. I will
Thank
find
you. I have to get better at reaching out.
what's needed to get. You should.
No, thank you. I will, because I'm not good at reaching out. So I will definitely take you up on that.
Believe me, I'll be reaching out to you again. But what we heard today really was, just to wrap this up, what we heard today is this is not a medical problem we're talking about. This is a community problem. This is a society problem. This is an economic problem. This is a human problem, isn't it? It kind of affects everything.